All right, this is chapter 22. We're only going to have time to hit the highlights, so we won't be using the PowerPoint. We're just going to go through here and talk about the most important things. These 3 chapters will be included on your final, so no test separately. Okay? All right. Chapter 22, page 500. Traumatic brain injuries or traumatic head injuries. First, we're going to start with a concussion. A concussion is a term used to describe a closed head injury when you have a brief disruption of level of consciousness. You may be out for hours, you may be out for seconds, but you'll have amnesia for the whole incident, won't remember it. Usually has quite a bit of a headache and sometimes nausea to go with it. Concussions usually heal quite fine. Remember, it's closed, so I don't have any. Well, I suppose you could have lacerations, but typically I will heal okay from a concussion unless I've had repeated concussions over and over and over, like people who are boxers or football players, something along those lines. At the top of 501, you'll see 3 bullet points. It says skull fractures are described as linear or depressed, simple or comminuted or compound, or closed and open. An open injury is when there's a laceration on the scalp, and a fracture of the skull with damage to the brain tissue. And a closed head injury is where the scalp and the skull remain intact, but the brain tissue is still damaged in some way, which can happen, and we're going to talk about that. Contusion is definitely a term to know. A contusion is bruising on the brain, and this happens when the little tiny vessels in the brain, they pop, they get injured, and they burst. So I have a buildup of blood, and I end up with a contusion. Now, your older adult care points talk about the brain atrophying in an older adult. So that means to get smaller. So you would think that that would keep them a little bit safer, but it absolutely does the exact opposite. That gives their brain more room to slosh back and forth in their cranium. And if you look at figure 22.1, you're going to see a couple of new words, a Chqp injury and a contra Chqp injury. A Chqp injury is if I slung my head forward real fast and hit it on something, my brain would actually slosh forward and hit my skull. And a contra Chqp would be when I did that and then my head flopped backwards and it did the same thing. Those are injuries that you typically see in shaken baby syndrome when they're shaking back and forth. Their brain just, hits back and forth on their skull. So with a smaller brain, an atrophied brain in an older adult, they actually have more room in there for brain injuries with a closed head injury. Subdural hematomas, epidural hematomas, and intracerebral hematomas are all listed in figure 22.2. Things to know about a cerebral hematoma. It's a little bit of a slower bleed than it would be with an epidural hematoma. They both can be life-threatening if they're left alone, if we don't fix them. But you can see that subdural hematoma and the epidural hematoma both are causing a collection of blood to be pressed in onto the brain, and that can cause quite a bit of issues. Anytime I press it in on the brain, then I can have a disruption of, depends on what part of brain it is, disruption, eyesight, speech, movement, pain, any of those things could happen. So I'm definitely probably going to see some changes, but confusion, things like that. So I definitely want to make sure that older adults are, they're safe. If they've had a head injury, that they're getting CAT scans and they're really looking closely. Not to say this couldn't happen to a younger adult, just more often in a older adult. And a subdural hematoma is typically the ones you'll see in an older adult when they fall. Under subdural hematoma, it says when a blow was delivered to the head, it may rupture the blood vessels that lie between the delicate arachnoid membrane that covers the brain and the tough fibrous dura mater. As the blood leaks under the dura mater, then we have that big hematoma that forms. And you can see that down in figure A, and that's pressing in on the brain. Now, an epidural hematoma next to it occurs more rarely, but when it does, there is a rapid leakage of blood from the middle meningeal artery. So this one's going to move faster. Okay, so this one, even though they both could be deadly, this one's probably going to be one that would get you faster. It says it's a medical emergency and you need a craniotomy, and that means that they're going to actually remove a piece of your cranium, your skull, and remove the blood. Your intracerebral hematoma, intra means inside, so you can see there's a bleed inside the brain. That's on the next page. It says it may occur within the brain from a blow to the head. Let's see here. Signs and symptoms. Severity of the brain damage from a head injury is best judged by the symptoms presented by the patient. A neurological assessment, so I'm asking all the neurological questions. What's your name and date of birth? What day is this? What month is this? Who's the president? Things along those lines. A history of the type of blow. What were you doing? Where did you hit your head? How long was you unconscious? Did anyone see it? Those are fantastic things to ask. Outward signs and symptoms of head injury include bruising and swelling. Do you see those things? Lacerations and bleeding of the head, of the ears or the nose. We'll talk about those in a minute. There may be a skull fracture with ecchymosis. Remember, that is bruising around the eyes. We call that raccoon eyes. That's never a good sign. Okay, and that's usually from, believe it or not, having a head injury in the back. We can also see battle sign. This is very important for you to know, and this is bruising behind the ear. This is also not a good sign. There may be autourea, which is fluid leaking from the ear. And there's autourea, and that's fluid, is usually cerebrospinal fluid, which means that we have a break in the casing around the skull. So very scary as well. Rhinorrhea, which is the same fluid leaking from the nose. And we're going to show you over here. Well, actually, we can do it right now. Figure 22.4 shows you a halo sign. And that is actually taking a piece of gauze and getting the drippings from the nose to see if they cause that halo. It says up here, assessing for a halo sign on fluid from the nose or ear after a head injury. The blood will draw together in the middle of the gauze pad, leaving a yellow ring around the blood, indicating the presence of cerebrospinal fluid. Nothing that you could use as a definitive diagnosis, but definitely something as a nurse you could do. Other things that you might see in these head injuries would be facial paralysis, difficulty hearing, tinnitus, a deviation of the gaze, anything that you could think of that would cause you to have some kind of spatial problem, right? You can't see right, you can't hear right, you can't taste right, any of those things, especially confusion as well. It says autourea and rhinorrhea should be tested to determine if there is cerebrospinal fluid, and that's the halo at the top. Testing with a dextro stick will determine whether glucose is present. The presence of glucose indicates cerebrospinal fluid. And bleeding into the subarachnoid space may be evidenced by nuchal rigidity, which is neck pain with flexion. Okay, so if I tried to put my head down, it would hurt so bad in my neck that it would be hard to move. Make sure you're looking at your clinical cues. If fluid from the ear or nose is tinged with blood, a dextro stick will not give results. Collect about a teaspoon of fluid on a white gauze pad, wait a few minutes, and look up at the top, and that's your halo sign. Box 22.1 is very important for you to know. Decreasing level of consciousness. Are they alert? Are they confused, lethargic, obtunded, stuporous, or comatose? Those are words that you want to use when you're charting. A lot of the times we're using alert or confused, or maybe even lethargic, because they're very sleepy acting, and that's quite common in a lot of head injuries. So we probably know those already, but obtunded, stuporous, and, well, we know comatose. But make sure you're paying attention to your levels of consciousness. Diagnosis, of course, we're going to use a CT scan and an MRI because we were able to see more clearly than we can with an X-ray. An EEG over to the side, you can see a lady hooked up to all those electrodes on her head. And EEG is going to help us to look at brainwave activity. So not a whole lot to pay attention to there. Treatment, patients with head injuries usually are initially treated conservatively. If the injury causes increased ICP or is a compound fracture of the skull, which means that the skull is broken, surgical debridement of the wound and removal of splintered bone from the brain tissues, or elevation of the skull fragment is performed. All measures to keep ICP from rising are instituted for serious head injuries. These are important. A patent airway must be secured at the head of a raised 20 to 30 degree bed. Okay, so that means if I have to have some kind of airway at the bedside, making sure their head stays elevated if we have an increased ICP or the risk of it is very important. Elevation helps to reduce ICP. Neurological signs are monitored closely. And the IV line is inserted for access for diuretic drugs if needed. Remember, diuretics are designed to pull fluid off of me. Now, I don't just use those willy-nilly in people with increased ICP. They try other ways to get it off first. But if I need to, then I can give them some kind of diuretic to pull that intracranial pressure down. Surgical intervention, a subdural hematoma is removed surgically either via burr holes, which are just holes that are drilled into the head, or by a craniotomy incision where they actually take off a piece of the skull. The hematoma is evacuated by suction or surgical instruments. For the preoperative period, this is for you. A patient with a hematoma is quickly prepped for surgery. The operative site is shaved after the patient is under anesthesia. For planned surgery, a shampoo may be ordered the evening before surgery. Not a lot to remember there. Post-operative is where you want to really want to pay attention. Positioning the patient according to written orders from the attending physician. Make no exceptions. Positioning is important to prevent added ICP. Keep the neck in midline and preventing excessive hip flexion to promote venous drainage from the head and keep ICP from rising. Use nasal suctioning only if there is a written order allowing this, because there may be a fracture that allows a pathway to the brain tissue. Could be bad. Watching carefully for signs of leakage of CSF from the nose, ear, and operative site, and reporting evidence of leakage immediately. Using aseptic technique and applying dressings to catch the drainage and prevent microorganisms from entering, because you probably have a direct pathway to the brain after surgery. Providing a quiet, non-stimulating environment, administering only those treatments, comfort measures, and medications for which there are specific orders, and reporting promptly any changes in the neuro status. Continued nursing management. Keep the patient on absolute bed rest with the head of the bed elevated 20 to 30 degrees to promote venous drainage. Cover a draining ear with sterile gauze. Change the pad periodically and look for drainage. Instruct the patient not to blow his nose or pick at it. Blowing it may increase the ICP. These are important. Do not plug the nose or ear for its drainage of CSF, because blockage can increase the ICP. Remind the patient that he is not to change his position in any way unless he has been told it is all right. And then you need to go help him. Okay? Very important. Make sure you're doing neuro exams continuously too. Your doctor will order how fast or how many minutes you need to have in between, but definitely make sure you're doing your neuro assessments. Now, for a neuro assessment, you want to make sure that you're asking. Let me see. It might be over here. I don't know if it's in here or not. For a neuro assessment, where asking those questions, those orientation questions, I might have my patient put their arms straight out and hold them out in front of them one at a time. And if they start to drift away, then I know there's a problem. I need to report a drift. I'll do the same thing with my legs one at a time. Also want to check Perla. Okay, I want to check their pupils to see if they're equal and reactive to light and accommodation. And that's a pretty basic neuro assessment. Okay. Also, I need to check for their reflexes. Okay, that's a really good one for a neuro assessment. Instructions for care of a patient with a head injury. Those are important. For the first 24 hours, awaken the person every 2 to 3 hours to be certain he can be easily aroused. Question the person about where he is, who you are, what happened, so on, to check orientation. Check the pupils. Patient should avoid strenuous activity for 48 hours. Apply an ice bag to areas of swelling for 20 minutes. Only 20 minutes at a time, because it can cause damage to the skin. For 48 hours, watch for and report any of the following signs. Change in LOC. Projectile vomiting is a huge one. Unusual dizziness, sleepiness, loss of balance. Change in vision, jerking movements of the eye. Increasing headache, any twitching that cannot be controlled, or seizures. Behavior that is odd. Those are all probably signs that you've got increased intracranial pressure. You've got a bleed in there somewhere pushing on the brain. Increased intracranial pressure, which we've talked about quite a bit. There's a certain amount of fluid that is around your spinal cord and your brain, and that is the amount that needs to be there. All right, no less, no more. I mean, a little less if they need to do an aspiration to check your fluid, but your body is continuously making it. All right, so after it's all, as I use it, I make more, and I use it and I make more, but it's at a very specified amount. And if I have injuries, then I can have increased intracranial pressure from swelling, or sometimes from an increase in just the fluid itself. Under increased intracranial pressure, you'll see any lesion or fluid accumulation that begins to take up space in the cranial cavity causes an increase in the pressure within the cavity, and guess what it does? It pushes on my brain. At the top, you can see that normal ICP is 0 to 15. Over on the concept map, we'll look at those in just a minute, because it's a wonderful concept map. Takes you through everything for ICP. Signs and symptoms. This is important. The earliest sign of increased ICP is lethargy and decreasing consciousness, accompanied by a slowing of speech and delayed response to verbal cues. Papilledema, which is swelling of the optic disc. viewed with an ophthalmoscope is a classic sign of ICP. Clinical cues, underneath you'll see we'll come back to that one. Classic signs of increased ICP, the first three of which are called the Cushing's triad, are rising systolic blood pressure, widening pulse pressure. That means a normal blood pressure, we'll say, I've got a blood pressure of 110/76. Okay, the pulse pressure is the systolic minus the diastolic. So if I had a wide pulse pressure, say 200/70, that's way too wide. There's too much numbers in between those two. So widening pulse pressure would be another sign. Bradycardia with full bounding pulse and rapid or irregular respirations. These signs tend to be late as our pupil changes, and they signal a severe emergency and need for immediate action to try to prevent the patient's death. All right. So remember, at the top, your early signs and then your late signs of increased ICP. Over on the concept map, you're going to see some things that cause ICP. At the top, you see brain injury, tissue injury caused by head trauma, a stroke, infection, inflammation, a tumor, an abscess, or an increase in the fluid. And that leads to inflammation and cerebral edema. Okay, so too much swelling around the brain, and I'm taking up too much room. This leads to vasodilation, so my vessels open up, which causes an increased intracranial pressure. My cerebral blood flow goes down, and then I end up with ischemia and hypoxia of brain tissue. Because of the increase in the pressure, my brain cannot get enough oxygen. And we know your brain has to get enough oxygen. Okay, if we don't get oxygen, then we have cell death, and that's the next step. Cell death leads to edema around necrotic tissue. All right, so necrotic means death. So if I have a piece of brain tissue that dies, then edema forms around that piece of necrosis. Then I get even more increased intracranial pressure. The pressure keeps going up. After that, I have herniation with compression of brainstem. Remember, if I get so much swelling that it's pressing on my brain and my brain has nowhere to go, it'll come out the bottom hole of your skull called the foramen magnum. And of course, your brainstem's already coming out that hole. So if your brain keeps pushing on the brainstem, which is the control center for a lot of things, then I'm going to be looking at some problems. If I have a herniation and compression, that's a disruption of the respiratory center. And then I have an accumulation of CO2. That causes vasodilation because I'm trying to get more oxygen to my tissues and trying to get more CO2 away from my tissues. And then I have even more intracranial pressure, increased intracranial pressure from the blood volume. This is all a big circle that ends up in death. Okay? All right. I know it's a lot to cover, but it's just where you can see that it's just one thing leads to another, and everything that happens leads to even more intracranial pressure. So that's how important it is to try to stop it before it gets too bad, and then you're getting treatment for it. Treatment, a patient with greatly increased ICP is usually placed in intensive care. It's treated with supportive care to keep the pressure from rising any further, and interventions to decrease cranial blood or CSF volume is maintained. Osmotic diuretics. Now remember, osmotic means water. Okay, so in osmosis, it was the movement of water. So an osmotic diuretic is designed to pull off fluid. Osmotic diuretics such as mannitol, and I want you to circle that one because that is the fancy one. That's the one that we always use is mannitol. Are administered to remove fluid from the body tissues, thereby reducing fluid in the brain. Dosage is determined by the body weight. It talks about Lasix. Lasix is sometimes given, but mannitol, because it is an osmotic diuretic and designed just to pull water and not a lot of other things, is going to be the best bet for increased cranial pressure. Dexamethasone is also another drug that's going to be important. Decadron may be given to decrease inflammatory response. It is a steroid, and we know that steroids decrease inflammation. Of course, we're going to talk about those again in pharm. Let's see here. We make sure we've got the head of the bed 20 to 30 degrees again. Neck must be kept positioned midline so I can promote venous drainage. Hip flexion should be less than 90 degrees. Rolled washcloth towels or trochanter rolls can be used for positioning. And that's just so they can't roll back and forth. Okay. If ICP is dangerously high as indicated by the Glasgow Coma Scale of 9 or less, and we're going to talk about that in a minute, and an abnormal CT scan, the surgeon may insert an intraventricular catheter into the lateral ventricle, through which CSF can be drained in small amounts. You don't have to remember that big long term. What they'll do, though, is they'll put something that's almost like a shunt that will drain out. okay? Just because I just keep on making too much. Remember, that has to be a Glasgow Coma scale of 9 or less and an abnormal CT scan for the surgeon to do that. Let me see if there's anything else here that you need. You don't have to worry about the cerebral perfusion pressures right now. You'll learn that if you go to an ICU unit. It's nothing that you can maintain right now. You would be taught that. It's just talking about how if they're draining things off, how to keep up with it. If the patient is on a ventilator and is extremely agitated, then you can give a drug to paralyze skeletal muscles. They do that a lot for people on vents anyway. Skipping down, it talks about barbiturates, sometimes used along with continuous brainwave monitoring when patients do not respond to more common therapies for reduction of ICP. The purpose of a barbiturate is to induce heavy sedation and slow metabolism, so I don't have that buildup of ICP. So that is a good one to remember for us today. Okay, barbiturates, mannitol, that was a drug we want to know what it does. Okay, that should be good there. All right, temperature control. The next part is achieved by placing the patient on a hypothermic blanket. Anytime we have a brain injury, we want the body to be a little bit cooler. So in most situations, at least. So we want them to go on a cooling blanket. Because when I have such a big problem with ICP and we have the increased pressure that it's going to be pressing in on my thermoregulation centers in my brain. So a lot of times these people have quite high temperatures, so we want to keep them cooled down. It says warm blankets and tepid baths can be used to raise the temperature of a hypothermic patient and prevent shivering. And DVT thrombosis phylaxis is started early because these people are not going to be moving. Anytime we have anybody stuck in the bed and they're not going to be moving, they're going to need DVT prophylaxis. So those are medications and therapies used to prevent the formation of blood clots. The guidelines for patients with ICP: conduct neurological checks at least once every hour. Sometimes your doctor orders them every 15 minutes. Report changes immediately. Maintain a patent airway and adequate ventilation to ensure proper oxygenation. Elevate the head of the bed 20 to 30 degrees. We've said that 5 times, must be important. Use measures to maintain normal body temperature. Elevations of temperature raise blood pressure, so we want to keep them cool. Shivering can also increase ICP, and that's where we would use the warm blankets. So just whatever intervention you need depending on the patient themselves. Monitor intake and output. Restrict or encourage fluids according to provider's order. If they've got a lot of intracranial pressure, they might restrict some fluids because that just adds to the fluid volume. Give passive range of motion. That's one thing we're going to do prophylactically for DVTs. Do not allow patient to become constipated, because when they have to press down to have a bowel movement that causes Valsalva maneuver and can damage the brain or cause more pressure. Hyperextend, flex, or rotate the patient's head. Don't do that. Remember, it stays midline. Do not flex the patient's hips, as in female catheterization. That's not promoting venous drainage. Place patient in Trendelenburg position for any... Do not place them in Trendelenburg. Remember, Trendelenburg is sitting them down where their head is lower. That just causes more pressure. We want to keep their head elevated 20 or 30 degrees. And allow patient to perform isometric exercises. And isometric are not ones that we actually have a lot of movement, but it might be pressing on your hands. Okay, that works the muscle as well. Complications of ICP. Damage to brain cells from injury during periods of ICP may cause residual scarring and seizures. Hydrocephalus is an excessive accumulation of CSF may occur, causing motor deficits, cranial nerve deficits, or decreased cognitive ability. That's about enough on that one, I think. Diabetes insipidus. Remember, we talked about diabetes insipidus. That is a problem when we have a brain injury, and that causes you to pee and pee and pee and pee and pee and pee. And diabetes insipidus is almost always caused by a brain injury or brain surgery. Nursing management. Let's see here. Data collection. We know what to look for. Always look at these bullet points under data collection. Diagnosis, planning, and implementation. Of course, we want to maintain cerebral perfusion, and that comes with the way that they are positioned in the bed, the way that they move, the way that their head or neck is positioned. We want to reduce ICP. Maintain adequate respirations, protect from injury. We know those things. Okay, injuries of the spine and spinal cord. So my spinal cord, of course, is protected by my vertebrae, but sometimes there is damage to the spinal cord, and we know that my spinal cord is a direct link. It's the pathway, the highway to the brain where everything is processed. So if I have an injury to my spinal cord, it could result or end that I have deficits in the rest of my body. If you look on page 510, you can see all the spinal nerves that are coming out of the spinal cord and the nerves that lead to the parts of the bodies that they control. So if I touch my finger, then I'm going to feel this. Okay, I don't actually feel it here. I feel it here, which is crazy. But that impulse goes up my finger, up my arm, all the way up to my spinal cord, and then from my spinal cord to my brain. Well, if I have a problem with an area of the spinal cord, then that sensation may never make it past the spinal cord, and it may never be perceived or received by my brain. Over to the side, that's just a picture of the dorsal roots, and dorsal roots are where the cell bodies extend out and numerous neurons connect to one place of the spinal cord, to the nerves. Not anything that you have to remember here. You did that back in A&P, so we're good there. But we want to know what happens when there's disruption in the spinal cord. Lots of things can happen there. It's not just accident. There could be tumors. There could be degeneration where as I get older, things happen to the vertebrae and there's injury there from the vertebrae. There could be spinal cord degeneration, infections, just anything you could think of. About 10 or 12 years ago, there was people who get injections in their back, and a company that made some of the steroids that went in the back actually sent out a lot of vials with fungus in them, a fungi, and it caused fungal meningitis, and a lot of those people didn't recover from it. So there's lots of things that can cause problems with my spinal cord, and we'll talk about some of those. Under pathophysiology, it says fracture, dislocation, or subluxation or partial dislocation of the vertebral column often results in spinal cord damage. You have to think, my vertebrae have a hole in them, my spinal cord goes down. If something happens to that vertebrae, it's a bone. If it shifts or gets broken, it could poke into the spinal cord, displace it, whatever. Cord injury is caused by compression, pulling, and twisting or tearing of the cord, with two types of injuries occurring, complete and incomplete. Complete injuries result in loss of function below the level of injury, and incomplete injuries result in various degrees of function and sensation. Just depends on how bad the injury is. So we'll say, and I always talk about the guy who played Superman. He had Christopher Reeves, he had a horsing accident, and I believe his spinal cord got severed at C2 or C3. Now look how high up that is. That means he lost function of everything that was controlled by those spinal nerves from C2 or 3 down. Oh God, that's horrible, isn't it? That's everything. Even his respirations. He lost respiratory centers. It was on a ventilator, I believe, for the rest of his life. So that would have been a complete problem. All right, he would have lost complete sensation. It says incomplete injuries result in various degrees of function and sensation. Penetrating trauma from gunshot or knife wounds or other types of accidents may cause severance, compression, or contusion of the spinal cord. Extreme flexation or hyperextension of the neck or falling on the buttocks, which causes flexion of the lower thoracic lumbar spine, may also cause spinal cord damage. Tumor growth can compress or destroy the spinal cord. I could have microscopic bleeding it says microscopic bleeding occurs in the gray matter immediately after spinal cord injury. Irritation of the cell causes edema to develop and spread along the next 1 or 2 cord segments, and the edema peaks in about 2 to 3 days and subsides in about 7 days after injury. So during the 2 or 3 days after you have injury, then you may not have a lot of movement at all. It may be, here and there. And then as the swelling goes down, then you might see more function come back. Hemodynamic instability with drops in blood pressure may cause decreased blood flow and hypoxia in the cord, increases the initial damage. The inflammatory process may injure the myelin covering on the axons. Remember, myelin are protective of your neurons. That's back in A&P, I know. But if I have destruction of the myelin that surrounds the axons of my neuron, then I have increased pain. That's what my myelin is there for, is protection. Now, that myelin does come back over time, but it's never like it was before. It never is as good as it was the first time. And then I may have electrolyte changes that can interrupt nerve impulses as well. Signs, symptoms, and diagnosis. The complete severance of the spinal cord or damage to the cord's entire thickness results in total loss of sensation and control. In the parts of the body below the point of injury, if the cord is damaged in the cervical region, the paralysis and loss of sensory Perception may include both arms and legs, which is tetraplegia, also called quadriplegic. Quad means 4. Severe injury to the cord above the level of the 5th cervical vertebrae is often fatal if emergency care is not immediate. And Christopher Reeves was above C5, I believe. Again, the phrenic nerve that controls the diaphragm, and that's the major muscle of respiration, is controlled there. So, of course, with his high of a problem at C3 or whatever it was, he needed a ventilator for the rest of his life. Interruption of the thoracic spinal cord through L1 and L2 causes paraplegia, which is paralysis of both legs. Para means 2. Injury to the spinal cord that does not involve complete severance of the spinal cord may result in temporary paralysis, which may subside as the spinal cord recovers from the swelling and an initial shock. Again, the swelling is going to be worse at 2 to 3 days and may actually swell the segments above and below the actual injury site. So you may actually see more problems in that swelling period than you would otherwise. Okay, and that'll continue to get better. On 512, you're going to see table 21.1, level of spinal cord damage. I don't really need you to know that. What I want you to know is definitely where the respiratory function is lost. All right, and I want you to know quadriplegia and paraplegia, where those happen at. Treatment to save the victim's life. Okay, to prevent further injury to the cord by carefully handling of the patient. Okay, I don't need to be twisting them, having them walk, or turning their head all over which places. To repair as much of the damaged cord as possible and to establish a routine of care that will improve and maintain the patient's state of health and prevent complications so that eventual physical, mental, and social rehabilitation is possible. Prevent further spinal injury is your safety alert. Anyone with a head injury is treated as if he has also suffered a spine injury until proven otherwise. The neck must be stabilized to prevent any movement, and that's why you see accidents with a seat collar on. They can't move anything until they verify that there's no injury at that portion of your spine. That would be life-threatening. Because a nurse or provider may not be at the scene of the accident to supervise the moving of a victim, laypersons should learn proper emergency care. Most people learn that from movies, honestly. To avoid flexion of the neck, no pillows or other kind of support is placed under the head. Do not move the victim unless life-threatening condition requires it. This is for people who come up on injury. But I do not want to put, you see the guy over to the side? He's actually got some Crutchfield tongs pulling, having some traction on his neck. But he has no, actually he might be on a pillow. He should not have a pillow, okay, until we decide what's wrong with him. Transfer the patient to the hospital should be done only by trained emergency medical technicians. All right, you're going to see down there some words. Methylprednisone, corticosteroids may be given as soon as the examination and diagnosis of cord injury are made. Well, those are steroids. And what are steroids designed to do? To take down inflammation. The faster we can take down the inflammation, which would be the swelling around the cord, the better we'll be able to see what the damage is. Normal saline is used for fluid replacement, and drugs such as dopamine may be given to sustain sufficient blood pressure. Don't worry really about dopamine right now, but do know that you give normal saline in this situation for this. Okay, normal saline is just what you need. It's just the same fluid type as my body. Right now, I don't need anything any different. Just the same fluid as my body. Respiratory management, intubation, and mechanical ventilation are often required to sustain life in patients with an injury above C5. Otherwise, they'll take it on a case-by-case basis. Immobilization and surgery. Cervical spine cord injury is usually treated with traction to immobilize the affected vertebrae and maintain alignment. And you can see that up above in figure 22.10, he has got traction to his head and neck. All right, and that's to stabilize so he can't move back and forth. Push up on his neck. All right, it's keeping a little bit of traction pulled so there's no further damage. Traction can be accomplished by skeletal traction using a Crutchfield or Gardner-Wells tongs and ropes. With pulleys and weights, he has got a skin traction, which means that he's actually probably got a weight attached to that other side that's actually pulling. A halo is often used for cord injury, not requiring surgery, and allows for early ambulation. Everybody's probably seen a halo. It looks like a metal cage that goes around the head, and that keeps the person from being able to move the head back and forth on the neck. All right, those are for people to wear for quite some time if they don't require surgery. Oh, there's a halo over there. Halo traction over on figure 22.11. Urinary management. These people usually are not moving. We don't want them to move, so they're going to get a Foley catheter. Psychological care. Short-term and long-term physiological changes are brought about brought about by spinal cord injury and paralysis are difficult, if not impossible, to measure. I will say, I know. Listen, we're supposed to be the cure-all to help everything with the patient. Just be understanding. All right. I know we're not trained as caseworkers, but we're expected to do that in a lot of situations, and guidance counselors and all those things. So all you got to do is take it slow, make sure the patients understand, be sympathetic. Nobody wants you crying and doting over them, all right? But try to be apathetic, I should say, Try to understand where they're coming from. They may be very agitated. They may be hostile because everything has changed in their life. Just be understanding, all right? Ask lots of open-ended questions. Sexual concerns. One of the area of concern of the patient and his family members sometimes receives inadequate attention is sexual function. Honestly, you probably could leave that to the doctor. Whether he or she will be able to have intercourse or feel intercourse ever again might be debatable. Women are also concerned they might not be able to have children anymore. And of course, that's going to be coming from the doctor, whether they think that's possible or not. Spinal shock and neurogenic shock is the disruption in the nerve communication pathways between the upper motor neurons and the lower motor neurons may cause spinal shock. It's characterized by flaccid paralysis and loss of reflex activity and sensation below the level of the injury. Spinal shock occurs immediately after injury and lasts for 48 hours to several weeks. Neurogenic shock may occur within 24 hours and is caused by a loss of vasomotor tone caused by injury to neurogenic shock. You know what? Don't worry about neurogenic shock. Just worry about spinal shock. Okay? Spinal shock is all we really need to know right here. There's not much on neurogenic shock anyway. Muscle spasms. Immediately after spinal cord injury, the patient will usually have flaccid type of paralysis. It's kind of wobbly. Later, as the cord adjusts to the injury, the paralysis will become more spastic. My muscle is trying to do something. The muscles are getting rigid, so you might see a lot of jerky movements. These muscle spasms, which may be violent enough to throw the patient from the bed or wheelchair, must be anticipated, and the patient must be secured so the accidents can be prevented. If the upper extremities are involved, he is likely to tip over glasses, water pitchers, or anything in his reach. Lots of understanding there, lots of education. Very scary for people. Autonomic dysreflexia or hyperreflexia is an inhibited and exaggerated reflex response of the autonomic nervous system to some form of stimulation that occurs in 85% of all patients who have spinal cord injury at or above the level of the 6th thoracic vertebrae. That one is to know. The autonomic dysreflexia response is potentially dangerous to the patient because it can produce vasoconstriction of the arterioles with an immediate elevation of blood pressure. Very important you put that immediate elevation of blood pressure back with AD. Because it can produce vasoconstriction of the arterioles with immediate elevation of blood pressure, the sudden hypertension can in turn cause a seizure, retinal hemorrhage, or a stroke. Less serious side effects include severe headache, changes in pulse rate, sweating, and flushing. AD occurs most often with spinal cord injuries at or above T6. Many kinds of stimulation can precipitate AD. Tight clothing around the waist may elicit AD. However, most are related to the bladder, bowel, and skin of the patient. For example, catheter changes in the distended bladder and insertion of a rectal suppository, enemas, and sudden change of position can stimulate and cause results in autonomic dysreflexia. When a patient exhibits these symptoms of AD, an emergency exists. Efforts should be made to lower blood pressure by placing the patient in a sitting position or elevating his head to a 45-degree angle. If the cause of the stimulation is known, for example, like an impacted bowel, overdistended bladder, or pressure against the skin, the stimulus should be removed as gently and quickly as possible, and the provider should be notified immediately. Orthostatic hypotension is also something that we already know, so we can get past this. Deep vein thrombosis is a huge complication for people who are paralyzed because of no movement in the bed. So we want to make sure that we are taking those precautions. Compression stockings, SCDs, they could be getting Lovenox or heparin. Infection, because I might not be able to breathe as deeply and as well as I could before. I am at huge risk for infections in the lungs. And because I cannot cough and I take those shallow breaths, then pneumonias are quite common. So we want to make sure that we are turning our patients, that we're, if we can, and if we're able to, if they're paralyzed, that we're giving them as much range of motion as possible. It also talks a little bit about ventilation, how if we are vented, if the patient's vented, then they have a high risk of getting an infection that way. And that's one of the biggest hospital-acquired infections is ventilator-associated pneumonia. Skin breakdown is absolutely huge in anybody who is paralyzed because they can't move. If we just leave them laying in the same position, the skin's going to break down. Renal complications, reflux from the bladder to the kidney often results in impaired bladder function. Most of these people are going to have catheters. Depends on where, if they can control their urination or if they can even empty at all. If they have a neurogenic bladder that's not working, they're going to have to be cathed. Some people who have partial paralysis are still able to hold their urine, so they'll be able to use urinals or bedpans, but a lot of times you're going to see Foley catheters. And I think, all right, we're going to skip over now to back pain and ruptured disc, a slip disc. Back pain is occurrence is surpassed only by headaches. Lots of people have back pain. We work hard, we exercise, we do a lot of lifting. Things can happen to our discs that separate our vertebrae. Our vertebrae, of course, are bone. They can't sit right on top of each other. So there's discs that separate them so that there's a cushion when we jump or walk or anything that we do, so the vertebrae do not rub up against each other. So sometimes we can have a disc that herniates or slips and causes some pain and pressure. Up at the top, it says causes of musculoskeletal back pain can include a lumbosacral strain, instability of the lumbosacral spine, osteoarthritis of the spine, intervertebral disc degeneration, which we're going to talk about, and herniation of the disc. Pathophysiology, the bodies of the spinal vertebrae lie flat on one another like a stack of coins. Between the vertebrae bodies are a disc of fibrous cartilage filled with gelatinous substance, that is our disc, that acts as a cushion to absorb the shock. This gelatinous disc may be ruptured by an injury, such as a strain, by heavy lifting, or by wrenching, in the spinal column or falling on the back. When the disc ruptures, part of the contents squeeze out from between the vertebrae, and disc fragments may lodge in the spinal canal. The disc compression on the adjacent nerve root causes pain. When proteins from the disc content leaks out into the canal, the body perceives it as a foreign substance, causing the inflammatory response, and that just causes swelling and pain. Okay, more blood flow to the site. I mean, if my body perceives it as alien, I want it to have an inflammatory response. It's just very painful here and doesn't do any good. Okay, person often suffers from what is sometimes called a slipped disc. Another name for this condition is herniated nucleus pulposus. Make sure you're always looking at your adult care points. Signs and symptoms and diagnosis. Sometimes a lumbar herniated disc causes pain radiating down the sciatic nerve because the sciatic nerve is being compressed by the vertebrae. So I might feel pain to the buttocks below the knee. Muscle weakness, paresthesias. Paresthesias, of course, not being able to move anything may occur. Cervical herniated disc cause pain in the neck and shoulder, radiating down the arm with numbness. Just depends on where the herniated disc is. There's always going to be some compression of a nerve root that's going to cause pain. Diagnosis requires a history and physical. The straight leg raising test is often for low back pain, so I put my leg straight out and I try to lift it up. If it pulls on anything, there's a lot of pain, then I'm pulling on a irritated nerve. It says, while the patient is supine, the leg is raised off the bed for examination table with the whole leg straight. If the low back pain occurs, then there's a disc problem. If conservative therapy does not relieve the pain, diagnostic radiographs, MRI, or CT can be performed. Initially, the treatment will be conservative and hope that this surgical correction will not be necessary. They'll probably give some steroids to take down the inflammation, some bed rest, some ice packs. Up at the top, it talks about complementary and alternative therapies. Make sure you look over that. Those are things that we typically don't do as a nurse, like acupuncture and acupressure. Massage is, we know how to do a little bit of a massage, right? But we're not a masseuse. So, and you have to worry about massage too. So, I mean, I would actually want the doctor to order a massage because I've seen people massage a leg before and it be a blood clot and the patient lose the leg. So, you got to be careful. It says studies show that wearing a portable heat wrap decreases pain moderately. We can have transcutaneous electrical nerve stimulation or a TENS unit. Acupuncture has proven to be good. People wear back braces. Whatever I need to do to take that pain away. Of course, I don't want to twist or lift or bend a whole lot, all that stuff. Swimming or walking for short distances is very beneficial because they're low impact. They don't put a lot of weight on your spinal column. Things that do cause a lot of problems are trampolines. All right. But anyway, if they have a spinal problem, I don't want them out running. Just a light walk and swimming is fantastic because it doesn't put any pressure on the spinal column, okay, on your vertebrae. Surgical procedures, if they can't find relief through conservative measures, then they can have a surgical removal of the damaged disc. A discectomy is performed to decompress the nerve root and take the pressure off the nerve itself so there's less pain. This is a microsurgical technique that uses a very small incision through which the herniated intervertebral disc material is dissected and extracted. It's minimally invasive. And some people who have a disc that's very high up, though, they go through the front of the neck. It's very strange. It talks about a spinal fusion a little bit on the next page. It says, it's 3 paragraphs down, a spinal fusion is necessary in some patients who stabilize the spine. In spinal fusion, a piece or pieces of bone from the iliac crest or cadaver bone are grafted into the vertebrae to strengthen them. Fixation with metal rods and screws may be employed by decreased spinal motion. All right, so I won't be able to move that piece of spine anymore. Unless you have a lot of fusions, you don't really notice it a whole lot. Nursing management, preoperatively before they go to have anything done with their spinal column, you want a baseline neurological assessment. So that when they come back, you know if there's a problem with their if they're having any neuro problems. So a baseline before they go. Other preoperative care is the same as for any other types of general surgery. We always start teaching pre-op, all right? So education pre-op. Post-operatively, the major concern after a spinal fusion, a laminectomy or a discectomy where we take the disc out. Don't worry about a laminectomy. But for spinal fusion and discectomy is to keep the spinal column in alignment so that healing can take place. Pillows are placed under the thighs when the patient is on his back and between the legs when he's on his side to maintain correct spinal alignment and decrease pressure on the back. We also want to make sure that if we have to be turned, that it's log rolling. If we log roll, that helps not to twist the side, so you need 2 people to roll. Sometimes the surgeon will allow the patient to be positioned only in the back and sometimes on the abdomen. Just depends on what's wrong with them and what they've done and who the doctor is. All right, I think that's enough for us to cover the high points in 22 right now.